So briefly, the TNM staging. TX is primary tumor cannot be assessed. T0 is no evidence of primary tumor. TIS is high-grade dysplasia defined as malignant cell confined to the epithelium by basement membrane. T1 is tumor invades lamina propria, muscular mucosa, submucosa. T1 is tumor invades the lamina propria or muscular mucosa. T1b is tumor invades the submucosa. T2 is tumor invades the muscular propria. Muscular propria invasion is T2 in all the tumor of all the organ except for the gallbladder, in which T1b is muscular mucosa involvement, muscular propria involvement, T1b, because there is no submucosa. T3 is tumor invades adventitia. T4 is tumor invades adjacent structures. T4 is tumor invades the pleura, pericardium, esophagus, vein, diaphragm, peritoneum, that are resectable structure. And T4b is when it invades the non-resectable structure and the tumor becomes unresectable, that is, it invades other adjacent structures such as the aorta, vertebral body or airway, which makes it unresectable. N1, N2, N3 is 1 to 2, 3 to 6 and 7 or more, as I discussed. And histological grades are G1, G2, G3, as we all know. Japanese classification is more extensive for the lymph node staging from AJCC. Another fundamental difference is that AJCC clumps together different tumor locations for lymph nodes, and total number of positive lymph nodes for N staging are counted, irrespective of the location of the lymph nodes. In Japanese staging, different for base tumor location and the extent of lymphadenectomy as per the location of tumor group. That is D0, there is no formal lymphadenectomy. D1 is group 1 lymph node dissection. D2 is group 2 lymph node dissection, and D3 is group 3 lymph node dissection. The extent of lymphadenectomy, the D0, D1, D2, D3 are related to the location of tumor, as in the gastric cancer. So the abdominal lymph nodes are divided from 1 to 20, and the thoracic and cervical lymph nodes are from 100 to 114. And one major difference is that this supraclavicular lymph node group in Japanese esophageal classification, that is 104, is still classified as extra-regional node in the latest 8th edition, that becomes it M1 status in AJCC, but it is still in the regional lymph nodes as per the Japanese classification of 11th edition of Japanese classification of lymph nodes for Ca Esophagus. So like I said, they have divided into D1, D2, D3 group, and according to number, like for cervical, that is encircled in the red this rectangle. So D1 will be 101 and 106 recurrent laryngeal nerve, and D2 will be, that N2 will be 102, 104, 105, and D3 will be number 100 lymph node station. So for every location they have divided the lymph node group in D1, D2, D3, and for so D3 dissection, one has to clear all the lymph nodes in D1, D2 and D3 group. So similarly for upper cervical, lower upper thoracic, middle thoracic, lower thoracic, abdominal, they have classified the lymph node group into N1, N2 and N3 groups. So what are the difference in squamous cell carcinoma versus adenocarcinoma? Though squamous cell carcinoma is commonly found in the middle and proximal part of esophagus. In squamous cell carcinoma, lymph node involvement is rare when tumor is confined to the mucosa, that is 0 to 7%. And lymph node involvement is approximately 50% of our patient tumor invading into submucosa. For more than 73% with transmural tumors has lymph node involvement. In adenocarcinoma, also correlate the lymph node involvement also correlates with the depth of tumor invasion, and tumor confined to the mucosa, the incidence mirrors that of squamous cell carcinoma, that is 0 to 7%. And penetration of submucosa, there is 15 to 50% lymph node involvement, and invasion of the muscularis propria is assured up to 80% involvement of the lymph nodes in adenocarcinoma. So this is the distribution of lymph nodes in case of squamous cell carcinoma and adenocarcinoma. So we can see that in case of squamous cell carcinoma, the involvement of the lymph nodes in the thorax is higher as compared to the involvement of the abdominal and low thoracic lymph nodes in adenocarcinoma, and the difference is significant in case of low adenocarcinoma. For the pre-operative lymph node assessment, the CT scan has pooled sensitivity of 30 to 60% for detecting enlarged lymph node that is more than 1 centimeter size. FDG PET CT has a low pooled sensitivity of approximately 51% in loco-regional nodal assessment, as nodes often get obscured by metabolic activity in the primary tumor. The EOS is highly sensitive, approximately 85% for assessing degree of the nodal involvement. Addition of FNA to EOS has shown the greater sensitivity and accuracy. In a study by Vasquez et al., they compared performance and characteristic of CT, endoscopic ultrasound, and EOS guide FNA for preoperative clinical lymph node staging in 125 patients. The EOS FNA combination was more sensitive than CT, that is 83%, 29%, that was significant, and the more accurate than CT, that is 87% versus 15%, again it was significant, and EOS alone, that is 87% versus 74%, which was not significant. The preoperative lymph node assessment PET CT role, the sensitivity of PET CT I said is low, but for detecting cervical, upper thoracic and abdominal node it is 78%, 82% and 60%. The sensitivity is 38% and 0% respectively for the mid and lower mediastinum. As it has already discussed that the lymph node activity gets masked by the primary. Retrospective review by Kesmani et al. 148 esophageal cancer who underwent total nodal staging by EOS FNA and FDG PET. The addition of FDG PET did not alter the nodal staging in any patient with EOS FNA. So the gold standard for nodal staging is EOS FNA, then EOS, then followed by PET and CT. So what is the rationale for lymphadenectomy? Why we should do lymphadenectomy in patients of Ca Esophagus? As the transarterial esophageectomy was the standard of care, so aim of extended lymphadenectomy for esophageal carcinoma is twofold. First is to accurately stage the disease. Second is to potentially cure the patient. This is a randomized trial by Halsher JV et al. I urge the viewers to go through this trial. This is a landmark trial. They randomly assigned 220 patients of adenocarcinoma mid to distal esophagus or gastric cardia involving the distal esophagus. The lymph node yield almost doubled between transarterial esophageectomy and versus transthoracic in-block esophageectomy groups 16 and 31 respectively. Although the median overall survival, disease-free and quality-adjusted survival did not differ statistically in this group, in this study, there was a trend toward improved long-term survival at 5 years with extended transthoracic approach. The oncological outcome of lymphadenectomy in THE versus en-bloc. The literature is riddled with problems of data compatibility between East and West, as we discussed already. In transarterial esophageectomy without formal lymphadenectomy known to have higher locoregional recurrence, the recurrence rate of series of 149 patients in Halsted group, the locoregional only in 23.4%, systemic only in 15.3%, total locoregional recurrence rate nearly 40%. Of this majority, 49% occurred in thoracic field where no lymph node dissection has taken place. The in-block esophageectomy data from demister group shown an isolated locoregional recurrence rate of 8% as compared with 23.4% in preceding THE series. In most published literature, locoregional recurrence after transarterial esophageectomy is much higher, that is 23 to 40%, as compared to in-block esophageectomy, that is 1 to 2%. So we have now a good literature evidence, including randomized controlled trial from reputed institutes, which has shown the benefit of external lymphadenectomy in case of Ca Esophagus. Three-field lymphadenectomy. The history of cervico-thoracoabdominal three-field lymph node dissection started from the reports by Kinoshita et al. In 1976 and Senhoi et al. In 1981. They emphasized that the esophageal cancer had frequent metastases in recurrent laryngeal nerve nodes and in supraclavicular lymph nodes. Based on these two reports, many surgeons adopted three-field lymph node dissection for cancer in thoracic esophagus. So, the cervical field node dissection during three-field lymphadenectomy for squamous cell carcinoma has shown a metastasis rate of 23.4 to 49.5%. In a series by Fizzuta, 750 patients, three-field lymphadenectomy, cervical lymph node positivity was 24% and cervical localization recurrence was only 14%, which was quite low as compared to the positivity. So, the incidence of metastasis in regional lymph node was higher, and they have grouped as seen in this table that the incidence of recurrence in upper, middle and lower they have given right and left. So for like even the lower thoracic esophageal cancer, there were chances of metastasis to the cervical paraesophageal lymph nodes and 3 and 1% case, 3 and 1 cases as highlighted in the this red rectangle. So these are the different series that cervical field dissection during three-field lymphadenectomy or squamous cell carcinoma has shown a metastasis rate of 23.4 to 49.5%. Three-field and two-field lymphadenectomy and long-term survival. Important landmark paper by Akiyama et al. Has shown that what three-field lymphadenectomy can do for long-term survival in esophageal cancer patient. In this series, 717 patients of squamous cell carcinoma who underwent RGO resection were analyzed, and 393 underwent two-field and 324 underwent three-field. The overall 5-year survival was 37.1% in K and versus 52.2% in two-field and three-field. The three-field lymphadenectomy led to 25% 5-year survival in subgroup of patients with positive cervical nodes. Patients with squamous cell carcinoma and positive stage after three-field if they had more than 7 positive lymph nodes, their lower survival rate despite radical procedure, that is 9% versus 51% 5-year survival. That showed that if the metastatic burden is high, then the extensive dissection, that is three-field lymphadenectomy, may not be helpful for the patient, but definitely it was helpful for early stage, early spread when the metastatic spread to lymph nodes was less than 7 in number. This is another landmark trial by Nishihara et al. Prospective randomized trial of extended cervical and superior mediastinal lymphadenectomy for carcinoma of thoracic esophagus. In this trial, they randomized 32 and 30 patients in three-field versus conventional. The 2-year survival was 83.3 versus 64.8. 5-year survival was 66.2 versus 48.48. Recurrence rate was 99.9 versus 24.1. The extended cervical and superior mediastinal lymphadenectomy may improve long-term result for carcinoma of thoracic esophagus. Since such cases were quite limited in this study, however, no definite conclusion could be drawn from this study. So, three-field lymphadenectomy and long-term survival. A series of by